greetings to everyone. I'm Dr. Brandy Fink from the Department of Psychiatry and Behavioral Sciences here at the OUHSC, and I've spoken to you before about alcohol use and intimate partner violence and family treatments for substance use disorders. And I thought it would be kind of timely if we talked about the current rates of alcohol consumption, because we saw pretty significant increases of them over during the period of the COVID pandemic, and those rates have stayed pretty steady. So, get my slides to advance. So what I'm hoping all of you will take away today is information about the current rates of alcohol consumption, how they increased during and after the COVID-19 pandemic. Also, learning how to screen for hazardous and harmful alcohol consumption, and then the elements of a brief intervention for hazardous and harmful alcohol consumption. I know we just even nationally, we have such a significant focus on illicit drug use, but alcohol use is actually much more costly to the United States than all other illicit use combined, including cannabis, opioids, and everything. So alcohol use, excessive alcohol use in the United States costs $249 billion annually. And most of this cost is the result of harmful or hazardous drinking, not alcohol dependence. That is often what is surprising to folks. So hazardous or harmful drinking comprises 77% of that $249 billion annually. So these are not the folks that we typically seeing presenting for treatment, either inpatient, outpatient, or intensive outpatient treatment for alcohol use. It's the entire other group of them. And we also have a pretty significant alcohol use problem in the state of Oklahoma. We are currently 13th in the nation for people with an alcohol use disorder who need treatment, but who are not receiving it. So it's of critical importance for us to keep at the forefront of our minds. So the consequences and why this is so costly to our society, the consequences from heavy drinking or harmful drinking, is all the associated unintentional injuries like motor vehicle accidents, falls, burns, alcohol poisoning. All of those are cause people to be utilizers of very expensive healthcare resources. We also see that violence is a consequence of heavy drinking. Sometimes can be bar fights, but a lot of this comes from intimate partner violence as well. We also see that sexually transmitted diseases occur more frequently after people have been drinking heavily because they're making poor choices when they're under acute alcohol intoxication. And we also see unintended pregnancy or poor pregnancy outcomes associated with heavy drinking, and this includes fetal alcohol spectrum disorders as well. And then we have difficulty controlling other chronic health conditions or causes is a contributing factor to other chronic health conditions like hypertension. High risk drinking, it can be a cause of hypertension. Diabetes, uncontrolled diabetes as well. Heavy drinking also raises the risk of a stroke, of heart disease, and of liver disease. And then lastly, heavy drinking is associated with an increase in a whole range of cancers. For women, it's an increase in breast cancer. For males and females, it's liver, colon, mouth, larynx, pharynx, esophagus, and rectum. So it's kind of the whole GI tract that is at risk for the development of cancers from heavy drinking. And so drinking during the pandemic, it caught a lot of us alcohol researchers by surprise at how much it really increased. We saw that for adults over age 30, drinking increased 14%, and risky drinking, such as binge drinking by adults over age 21, increased by 21%. So this is 4 or more drinks for a woman and 5 or more drinks for a man. That increased by 21%. And then heavy drinking, which is considered more than 7 drinks per week for women and more than 14 drinks per week for men, increased by 29% during the pandemic. And these increased drinking rates have been witnessed across socioeconomic and age groups. So the pandemic had a pretty consistent effect across the population on their drinking. And we saw a significant increase in retail alcohol sales at the beginning of the pandemic, and those have continued at early pandemic rates. So now that we're kind of out of the pandemic and things have returned to normal, people's drinking has not returned to normal. It has stayed at these very high levels. And the consequences of this are startling. There's been some statistical modeling done that reveals that just 1 year of this increased alcohol consumption will lead to almost 20,000 new and additional cases of advanced liver cirrhosis. And so what if we had about 2.5 years of this? So this is really significant. And there was one hospital, this is at my old institution. And just at that one hospital, they reported a 25% increase in number of patients with alcohol hepatitis in 2020 alone. Now, the state of New Mexico is #1 in the country in alcohol-related harm. So this is pretty significant. The interesting thing about New Mexico, though, and the UNM hospital is they do not have a liver transplant program like we have here at OUHSC. And so I'm one of the providers in our transplant program here. And I mean, it's just an overwhelming number of people with alcohol-related liver disease who are presenting for transplants. And we also have recent estimates that suggest that alcohol-related deaths increased 25% just during the first year of the pandemic. So this is just devastating. And that alcohol-related deaths outpaced COVID-related deaths among those under age 65. Now I'm going to couch this a little bit because most individuals who died from complications of COVID were over the age of 65, but people who were younger who had obesity, diabetes, heart disease, and things like that were at significant risk of death from COVID if they were under age 65. So this is a huge increase in the number of alcohol-related deaths in the first year of the pandemic. So everybody began tracking this information right away, and we're just starting to see these studies published, as you can see by some of the dates on these publications. And then the alcohol problems and the negative consequences have persisted since the pandemic essentially ended. So you know, I mentioned that our drinking rates have not decreased. Well, certainly neither have the problems or the negative consequences associated with the alcohol use that increased during the pandemic. So that's all doom and gloom and frightening and shocking as and things like that. But there are some things that we can do to help people. So the first thing to do is screen for high-risk alcohol use amongst all patients that we see. I do this with every new patient I have, whether they're seeing me for depression or anxiety or substance use disorder. And as I mentioned earlier on, most of the alcohol-related harm results from harmful or hazardous drinking, not from alcohol dependence. And just to reinforce, we consider binge drinking being more than 3 standard drinks for females and more than 4 standard drinks for males. And then weekly drinking becomes hazardous or harmful if it's more than 7 standard drinks in a week for females and more than 14 standard drinks in a week for males. So why the sex difference here in this? Anybody want to venture a guess or have some knowledge?
Well, women don't metabolize alcohol in the same way that men do.
That's correct. Yep. We have more body fat, so alcohol is more concentrated in our female bodies, and we also have less alcohol dehydrogenase in our stomachs, which is the enzyme that does first pass metabolism of alcohol before it's absorbed into the blood system in the small intestine. So this is why we always recommend too, if you're going to have an alcohol beverage, make sure you're eating something at the same time. That keeps the alcohol in your stomach longer and allows it to metabolize before being absorbed into the bloodstream in the small intestine. So that's where alcohol gets absorbed into the bloodstream. So, and then we see just normally pre-pandemic rates that at least 20% of primary care patients drink at harmful or hazardous levels. And the approach to dealing with this level of drinking from the World Health Organization and from a public health perspective has been to do screening and brief interventions in these general medical settings. So this has been the approach of the World Health Organization since 1979, and we just have had no foothold in it. So I have another line of research that's looking at using artificial intelligence to deliver these brief interventions and things on behalf of providers, because it's just not getting done, because primary care providers are asked to do everything and they get a little overwhelmed. And so I briefly mentioned standard drinks. And so I'd like to take a few seconds here and just remind the group of what is considered a standard drink so that you can properly advise your clients about what are low risk levels of alcohol consumption. So we are trying to get an equivalent amount of pure ethanol across beverages. So this is what a US standard drink is. And for just beer, about 5% alcohol beer. So this is your standard Coors Light, Bud Light, Budweiser, Natural Light 12-ounce beer has about 5% alcohol in it, and 12 ounces of that is considered one standard drink. When we are moving to malt liquors or flavored malt beverages like hard seltzers, like White Claw and things like that, the alcohol content of those beverages is higher. It's about 7%. So one standard drink is only 8 to 10 fluid ounces of those beverages. And when we get into some microbrews, they tend to fall into this higher alcohol concentration category. So I've seen some as high as 8%. And in the microbreweries that I've visited, often the brewery themselves limit people to only 2 of those beverages, but they're often serving them in a pint glass. So that's 16 ounces of that, when just 8 to 10 ounces is a standard drink. So in 1 pint of a microbrew could be 2 standard drinks. So that's important that people understand that breakdown. And when I'm meeting with clients, I pull out this chart and we go through it so that we're all on the same page. So when we're talking about table wine, like a Cabernet or a Merlot or something, that has about 12% alcohol in it. And so one standard drink of wine is only 5 ounces. And it's really only about this much in a wine glass. So some restaurants will ask, do you want a small or a tall pour? And even sometimes the small pour is 6 ounces and the tall pour is 12. So if you're taking a wine glass and filling it up, that's probably could be up to 2.5 standard drinks. So 5 ounces in a wine glass is about this much in a wine glass. And then if we're talking about a fortified wine, like a sherry or a port, that has 17% alcohol in it. So a standard drink is only 3 to 4 fluid ounces of a fortified wine like that. Then if we're talking about a cordial or a liqueur or an aperitif, that has 24% alcohol in those beverages. And a standard drink then is only 2 to 3 fluid ounces of those beverages. And then when we're talking about brandy or cognac, that has about 40% alcohol. That's most hard liquors are 80 proof, and that's equivalent to 40% alcohol. But if you're drinking some other bourbons and things like that, they can be 100 or much higher proof. A friend accidentally bought 150 proof Knob Creek one evening. I like bourbon, and I was quite surprised to find I was quite intoxicated after one drink. So you have to kind of pay attention to what the proof is on those alcohols. But when we're talking about these distilled spirits, it then is 1.5 ounces, fluid ounces of a distilled spirit. So that's gin, rum, tequila, vodka, whiskey, etc. So when you're orienting your patients and your clients to what is low risk drinking, so for women again, that's no more than 1 drink in a day, no more than 7 in a week, and certainly no more than 3 at one time. And then it's 2 for men, no more than 4 at one time, and no more than 14 in a week. These are the calculations for that. And so what else do? We give them some information about what low risk drinking is. And then it's advised to do a screening, brief intervention, and referral to treatment procedure or an ESPERT procedure. And the first step to this is screening. And I always recommend the use of the alcohol use identification test or the audit. This was developed by the World Health Organization. It's been translated and validated in over 40 languages. So this goes very far into reducing health inequity, because we can ask huge numbers of individuals about their drinking. And it's also used quite commonly in research and in clinical settings. So we have a nice uniform benchmark across treatment settings for this. And so when we do the screening, so let's say we've used the audit to do the screening, and our client comes back with an audit score of 0 to 7. This is also the beauty of using the audit, is it's broken down into, depending on what the score is for the patient, tells you how you ought to intervene with them. So if a patient scores 0 to 7, they're in the low risk range. For drinking, you can provide them some feedback about their drinking. I always tell them that, you've screened in the low risk range and what that low risk range is, and don't change that, because some people are unaware. I mean, most of my clients have no idea what low risk drinking is, or what drinking in moderation is, when they say that in, beer commercials and things. And then no further action is needed at that point. But myself personally, I always make a point of providing some feedback about their drinking. And if a client scores an 8 to a 14, they are drinking in a hazardous or harmful range. And so remember, this is where most of the cost of drinking comes from to the United States. And at this level, feedback and a brief intervention is the appropriate course of action to take. And then if we have a client who scores a 15 or above, this is considered the alcohol dependent range. So this individual is likely to need a drink in the morning to get themselves going, especially after a day of heavy drinking, because they're in alcohol withdrawal. They may have some shakiness in things when they're not drinking. And we may need some medically supervised detoxification for them. So if they're scoring 15 or above, we want to provide them feedback about their scoring and that they've scored in an alcohol dependent range. That, if you or yourself are not, do not feel competent to treat and further assess the alcohol use, that you'd like to make them a referral to someone who can. And then also assess them for the need for medically supervised detoxification. Alcohol is really the only substance for which withdrawal is lethal. This can cause a potentially lethal seizure for the patient. So if someone is drinking and showing signs of dependence, they do need a medically supervised detoxification. And then potential pharmacotherapy to help them maintain their abstinence. And so if you are a skilled substance use counselor, you can do an outpatient, we can do outpatient detoxification as well. I will back up here a second. So not all detoxification needs to be in a hospital setting. It can be monitored in an outpatient setting through the use of medications, but that'll be up to the physician who's doing the detoxification. Here at our OU system, we have the luxury at our OU Edmond facility of having a medically supervised inpatient detox. So patients will go and stay there for about 3 or 4 days, 5 days, depending on the level of alcohol dependence, and then come back to us for outpatient treatment. And then, some providers feel comfortable administering those medications in an outpatient setting. If you have experience treating alcohol use disorders, you can also do a taper with drinking patients where each day they reduce their drinking by 1 standard drink. That is also considered a safe protocol for detoxification. And it takes about 2 weeks, 12 to 14 days to reach no drinking at that point. So when we are doing a brief intervention with our patients, I recommend the FRAMES framework, for delivering a brief intervention. And so it has, FRAMES is an acronym for feedback, responsibility, advice, menu of options, empathy, and self-efficacy. So if you kind of keep that acronym in mind, it's a good way to guide your intervention with them. So the feedback component of the FRAMES brief intervention is just giving them feedback about their drinking in relation to what low risk drinking is. So you may say something to your patient like, you've scored a 16 on the audit, which indicates that you are at high risk of harm from your drinking. So I want to really emphasize this approach to talking to patients about drinking, because we have a whole host of notions and expectancies around somebody who presents with an alcohol use disorder, and the clients do too. They think if they admit that they've kind of lost control of their drinking, that they have to admit that they're an alcoholic and they have no control over it. And a lot of people are very resistant to that level of terminology, which feels very pejorative and judgmental to them. So it's really just talking about their drinking in relation to the harm that it's causing to their health and their social functioning at that point. And I've never had a client who's not found that approach just helpful. And really in hazardous and harmful drinking, just providing people with this brief intervention has been shown to be effective in reducing drinking to low risk levels. So it will reduce high risk drinking by at least 8 drinks a week for a man. And that's often enough to get them down into a low risk level. And when I've often had a lot of press interest in my alcohol-related partner violence research. So I'd have TV crews and things come and we'd show them some of the study procedures that we're doing. And just in me talking about what low-risk drinking is, just in that setting, with a lot of those camera crews and things, they all kind of would walk away and they're like, you know what, I think I'm going to keep an eye on my drinking. I think I might be drinking more than what's healthy. And I just felt so proud of myself. I did a brief intervention and I didn't even know it. So anyway, these are very effective. This feedback is very effective at reducing harmful or hazardous drinking in folks. The second part of the FRAMES approach is responsibility. So this is helping a client acknowledge they are responsible for their own behavior and can make choices about their own alcohol use. I'm not the one trying to convince them that they need to change their behavior. I'm going to collaborate with them on that, but it's up to them what they want to do. So an example of how you might approach someone like a conversation like this is, so what do you do with this information that what you do with this information that I'm giving you is up to you. How concerned are you about your score? So these open-ended questions that allow for exploring of the problem is the best approach. And you can also use the importance and confidence rulers in discussing this. And so on this slide, we've got, here's the importance the importance ruler. So on a scale from 0 to 10, how important is reducing your drinking to you? And they might be like, wow, based on what you said, maybe it's like a 7. And so I'd say, okay, so tell me why you're a 7 and not a 5. And then they can say, well, you know, I've been kind of having trouble controlling my blood pressure and my hypertension. And you know, maybe if I cut down on my drinking, that might help that. I'm like, oh, that's great. So that sounds like it's very important to you. And then I can ask them, so how confident do you feel in your ability to reduce your drinking on a scale from 0 to 10? And they're like, well, I'm probably about a 6 on the confidence scale. And I can ask them then, so tell me why you're a 6 and not an 8. And shoot, I'm sorry, let me interrupt this for a second. My home alarm is going off. How embarrassing. Sorry, everyone. I should have disarmed that for him before he pulled up. So back to the confidence ruler. So let's say my client says, you know, I'm kind of a 6 on this. So I'll ask, so tell me why you're a 6 and not an 8. And they're like, well, you know, everybody, all we do with all my friends is go out and drink. You know, and that's like we get together and watch football and we're drinking during that. And so that, you know, opens the door for us to explore how, you know, what can I help you with? And maybe reducing your drinking or setting some parameters around your drinking so that you reduce it in those types of setting, either through drink refusals or, you know, using a time frame like from noon to 3 o'clock, I just have 1 beer. From 3 o'clock to 6 o'clock, I have my second, or something like that. So just helping them have some structure around that. And our next component of the brief intervention from the frames perspective is advice. So providing clear advice on how to reduce the harm that's associated with continued drinking. And this can be, I encourage just a straightforward statement here, and like the best way you can reduce your risk is to cut down or to stop completely. So I want to give them clear advice from my perspective, what is going to be in their best interest here. And then with a menu of options, you know, of how to best go about cutting down, like I had mentioned, with the drinking, maybe when friends get together to watch football, that could be one of the menu of options that the person can choose from to reduce their drinking. And the nice thing about using this menu of options approach is it really reinforces the sense of personal control the person has over their drinking and their own responsibility for making a change. So they're not doing something because I think they should do it, or they have to, you know, or I'm berating them into reducing their drinking and saying, you know, it's bad for you. They're taking responsibility for their own good health. And this may also strengthen the attitude for them to actually go ahead and make this change. So one strategy for reducing drinking is just keeping a diary of their substance use and mentioning in that details of where, when, why, how much, and with whom that they tended to drink. Also identifying high-risk situations and strategies to avoid them. So if high-risk drinking takes place when they're watching football on the weekends, so what do we do in that situation to reduce the risk of high-risk drinking? And then identifying substitute activities instead of substance use, like hobbies, exercises, sports, spending time with the family in ways that don't involve the use of any alcohol. And then encouraging the client to identify people who could support them and help with changes that they want to make. So let's, this is really powerful. And this is why a big focus of my research is in this area. But if they have one person who is really in their corner for helping them and supporting them and making this change in a non-judgmental way, the person has a great deal more likelihood of sustaining a change in their drinking. So let's say it's a partner in the home, their spouse or boyfriend, girlfriend, or partner is concerned about their health. So that would certainly be someone they could potentially turn to provide support in this. And that can include making strategies for, maybe bringing some non-alcohol beverages over to the friend's house when they watch football, and alternating, one beer and then 2 sodas or something like that. And then also a very effective strategy is to have folks set aside the money that they would normally spend on alcohol and set it aside for the use of some other specific purpose. So let's say there's, a concert they really want to see, and, this would help them save up for the tickets for, that person and a friend to go to the concert or anything like that. It can be these small, I encourage, smaller other activities, as well as some kind of longer term goals. So let's say you want to take a weekend trip or something. This would help save money, for that as well. But it's good to have something immediate, something more long term, and something very long term, so that a person's not just not getting any reinforcement for not drinking. And then we have empathy here. And this is a strong recommendation, is taking a compassionate, understanding, accepting, non-judgmental approach that attempts to understand the client's perspective with their drinking, including understanding that the patient may not be quite ready to make a change yet, and reflecting that back to them. And just, in a very non-judgmental way, saying it sounds like you're just not quite ready to make a change in your drinking yet. And often people will be like, no, I think I can probably reduce it a little bit. So it elicits that change talk, which is very prognostic in being able to have someone reduce their drinking. And so some things that you may be able to say to the client is, I know this process can be confusing. I know it can be kind of overwhelming to learn that you're drinking at a hazardous level or in a way that it's negatively affecting your health. Also, I'm sorry to see that you're in this situation. I'd like to help if I can, and let's see if we can solve this together. So you develop a very collaborative approach to working with a client. And there's just decades and decades of research that supports this approach for making positive changes in a person's drinking. And then the last part of the FRAMES model is self-efficacy here. And so what we really want to do is foster the person's confidence in making changes to their alcohol use. Keep in mind that solutions are usually evoked from the client rather than provided by the therapist. If I start to feel like I'm working harder in the therapy session than my client, then I know I'm over-involved and I need to slow down and step back and give it back to my client. And one way to keep this person's sense of self-efficacy and their confidence improving and being able to reduce their drinking is summarizing what they've said. You know, so just summarizing the conversation. So, you know, today you learned that you're drinking in a way that is likely to negatively affect your health and your social functioning. And that was pretty shocking and scary to you, but I think we've come up with some really good strategies for how you can reduce your drinking to low risk levels. And, you know, you're a little bit on the fence about whether or not you want to try it, but you've identified someone in your life who's really committed to helping support you in this way. And maybe that will help bolster your confidence in being able to do it. And they would be like, yeah, that's right. You know, so it ties it up in a nice little package for them. If you sense any resistance from the client, that is a signal to you to respond differently to them. You may have gotten a little too much into trying to convince them that they need to change their drinking. And that's your signal to say, to remind yourself that, hey, this is up to you. You know, I've just given you some information. What you do with it after you leave here is up to you, but I'm here to support you in that decision. And you'll notice immediately, it's like the client and the therapist are both pulling on the rope. And as soon as you respond differently, it's like you've dropped that rope and all the tension is falling out of it. And then questions and problems that the client has, like if they are saying, well, problem with me stopping drinking is people are going to think I'm less fun and stuff like that. Return that to them for their solution. You don't have to be the problem solver in that situation from them. Return that to them for what's going to be a solution, because if they identify the solution, it's much more likely to work for that person in their life and in those settings. And then I think that's all I've got today. So we have some time for questions and comments and a bright future for our alcohol consuming individuals.
These assessments, can anyone use those, or do you have to have permission to use them?
Nope, they're totally free. Let me go back, because I put the website here. If you go to the auditscreen.org website, it is beautiful. It will walk you through how to use the instrument, how to score it. You have free access to them there. Often, if you're working in a health system like OUH, OU Health here, then we should have it in our EHR for use as well. For myself, I always like to just print a copy out because I can make notes of it. So it's free. You can, on this website, you have access to all the languages that it's been translated into. And it also has a beautiful method of guiding you through doing a brief intervention with patients, you know, so you can practice it. And, you know, this approach has really been designed for general medical settings. So it's designed for people who don't have particular expertise in treating substance use disorders, which makes it really accessible to the general person. You don't have to have necessarily expertise in treating substance use disorders to use it. But I encourage you to visit the website. It's really a wealth of supportive help and resources, and you can even refer your client there as well. It has some self-guided exercises for them too. Another good resource that I didn't put up here, but it's at the National Institute on Alcohol Abuse and Alcoholism, NIAAA, niaaa.nih.gov. They have great resources there too, including Rethinking Your Drinking. Is a whole beautiful webpage that gives people feedback about their drinking and strategies for reducing it to low risk levels. Anyone else with any questions or comments?
I always use the Addiction Severity Index, but it's quite long and, you know, somewhat cumbersome, and this seems brief and
Yep.
straight to the point.
Yep,
It's so much time.
yep, and
I've
the
seen this
intervention,
before, this SBIRT. I've seen it in literature, but
yeah,
now I know where to go look at it and everything.
yep, good. I'm glad this was this was helpful. Yeah, and it's a really accessible approach. And if anybody in the group ever has any questions about it, or they want to use it with a client, just shoot me an email. I'd be happy to, you know, provide some consultation for you on that as well. It's brandy-fink@ouhsc.edu. And you know, I have a strong, I'm like, no one needs to suffer. No one needs to have their life completely decimated by a substance use disorder. And so the earlier that we can intervene, the greater likelihood that we have of preventing it continuing to the point where it just completely destroys a person's life. I mean, I feel passionately about that with depression and anxiety. If we can identify it when it's a small problem and intervene, then we prevent human suffering in our clients. Any other comments or questions from the group? Okay. Well, I'm going to turn everybody loose for the weekend. I hope you all have a wonderful Thanksgiving holiday. Oh, I see one question that's come up in the chat. Oh, just thanks. You're very welcome, Carrie. Just have a great Thanksgiving holiday, and we'll see you week after next. Okay.
Thank you.
You're welcome. Bye, everyone.
Bye-bye.